Alright guys, time for lower extremity. It consists of the tib fib and the knee. So starting with the tib fib, we got two views, AP and lateral. No matter what, if it's a standard outpatient or a trauma, we're going to try and get the AP and the lateral as best we can. So starting with the AP, distal end looks like a nice AP ankle with the dorsiflexion of the foot. So we can see that nice joint space there and the distal end of the fibula. And at the proximal end here, we can see slight superimposition of the fibula head behind the tibia. Alright, let's talk about technique. So we have a 40-inch SID with no grid. We got 60 kVp, anywhere from 2 to 4 mass. And our S value should be anywhere from 150 to 400. And this looks very similar to upper extremity because it is. So don't overcomplicate these things for yourselves. So again, just to reiterate, we're going to use our lateral malleolus, the most distal point on our tib fib, as our reference point for our image receptor placement. The corner of that image receptor, you should be able to see the shadow of that distal tib fib. And then rotate it diagonally at that point using your pivot point to match the anatomy. Alright, moving on to the bee's knees, the cat's pajamas, the standard knee series, the PA standing Rosenberg, just AP standing, lateral standing, and a sunrise view. 40-inch SID with a grid for a larger patient. You're going to be using 80 kVp with something like 4 to 8 mass. Okay, and if you're not using a grid for a smaller patient here, we're going to go all the way down to like 60, 65 kVp at like 2 to 4 mass. Okay, you can see the big difference with and without a grid. Okay, that'll save dose for patients that don't have a lot of soft tissue there, and you'll still get really good imaging. Our S value should be anywhere from 150 to 400 again, just like any extremity. And our sunrise view differs a tiny bit. It's somewhere in the middle of the two. So 70 kVp, 2 to 4 mass. Again, anywhere from 65 to 75. You can't go wrong. So keep that in mind when you're setting techniques for these images. So this is a pretty average technique that you're going to see when you're setting someone up for the upright bucky. You can see here I got my upright bucky selected and I have a fixed mass of 4 here. I'm not using the AEC cells over here. Okay, so make sure you're adjusting your mass accordingly. Again, anywhere from 70 to 80 kVp with or without a grid. That's all depending, okay? Use your chart that's next to you in the room.
So depending on how old your patient is, depending on whether you're doing both knees or just the single knee of interest. If the patient is 45 years or older, then we're going to be doing both bilateral knees regardless of the order. If it's just a right knee ordered, we're going to be doing the AP and the PA bilaterally. The lateral and sunrise will always be individual exposures. Okay, so keep that in mind. Always ask a tech to double check and confirm. Make sure you're going to be doing the right thing. Here we have some great x-rays for you guys to reference. We'll start with the Rosenberg. You can see the nice tunnel view there.
So you should set your tube angle before you even get the patient in the room. Get as much set up before that as possible. We're going to have a 20-degree angle on our tube, anywhere from 10 to 20. Here I got 15, feet pointed forward, and we're going to have our patient bend into the board so their knees are touching it. And you can see our central ray is at the apex of the patella, and everything is in good positioning. Just going to have sit down a little bit, get a nice 45-degree bend in those knees. That's important. You're going to get a nice tunnel by doing that. You can see right here a good view of where that laser beam is exiting right at the apex of the patella. Pretty easy to see. So that leaves us only a couple things left to do here. Just make sure our feet still pointed forward. Always double check positioning and then put our marker right there. Whatever one's closest to you, mark that side. And that's how it should look. Nice Rosenberg.
Now when it comes to the APs, again 45 years and older, we're doing the bilateral. This is how it should look.
So when we turn our patient around, we got to really make sure that the feet are facing forward. You can see Shannon's feet now pointed towards the corner of the room. We got to make sure we're going to point them towards our tube, bring them close together so we fit it onto the image receptor, and we have to take off our angle on our tube. Okay, so we're going to do a horizontal beam here for our AP, 90 degrees. Okay. Then when we lower this, you see, like if you had good positioning for your PA, use that dotted line as a reference. Okay, the difference in the angle is going to be the difference in your central ray right there. So the only thing left to do, a couple things, we just have to reset our board to center it, which if you're setting a technique isn't completely necessary, but we definitely need to switch our marker here because we're turning them around. So now that's the right knee. It's extra important to make sure that your patient stays centered so both knees are on the image if needed.
Now moving on to the lateral, you can see in this X-ray here, perfect superimposition of the femoral condyles. That's what you should be looking for. And slight superimposition here of the fibular head.
When you first stand someone up against the bucky, have them stand parallel like this. And then what you're going to have them do is take a step back with their other foot. Focus on a 45-degree bend.
And last but not least, we have the sunrise view. Right here, it's our tangential view of the knee, the patella, and there's many ways to do it. I'm going to show you a couple of ways here.
So try not to forget to put that cephalic angle of 5 degrees on for your laterals. And really try to set techniques instead of using AEC. You're going to save yourself a lot of repeats. Double check your S number after every exposure. I can't stress that enough. A lot of things can go wrong with knee x-rays when it comes to technique, so really pay attention to that. Get in the habit of it now. And that leads us into trauma knees. So our trauma protocol is for anybody that cannot stand or has been in a trauma. In the ED, we're never doing a standard protocol of the standing Rosenberg series. We're doing the trauma series on the table with an AP, an internal oblique, an external oblique, and then a cross table lateral. So when it comes to our imaging for traumas, we'll start with the AP. You see here we have slight superimposition of the fibula head behind the tibia. We have equidistant epicondyles. It's nice and in line, no distortion. That's what we want to see. For our obliques, they're very different pictures. The internal oblique here, we see no superimposition at all of the fibular head. So we see that joint space between the tibia and the fibula. And when we go to our external oblique, we should see the fibula completely superimposed by the tibia, which we see here.
Now Shannon's just going to rotate her foot in, but it's important to rotate the whole leg in. Have the femur and the tibia both rotate together to achieve this internal rotation. Then all we'll have to do left is just fix our tube. We'll still be centered a little bit more lateral than normal for our AP. And for the external, we're just going to roll out the opposite way. Our central ray, place our marker, and we are good to go. That's good collimation, good external rotation.
So this takes us to the cross table lateral. It's a very satisfying image when you get it right. Getting those condyles lined up with each other. Again, if we're going to put a 5-degree cephalic angle when they're standing, it's a medial-lateral projection. When they're laying down in a lateral medial projection, we're going to have to put a 5-degree caudal angle on the tube. So keep that in mind. It's going to really help out your pictures, make them come out really good. I'll show you some examples on how to do that.
So say a patient comes in and they're in way too much pain. They can't roll their leg in at all. It hurts when you try to roll them in. There's still a way we can get this done. So the main goal of this is going to be to match our tube angle with our image receptor. That's how we're going to eliminate distortion here. So you can see I got my tube angled in, and I have my board also angled to match. See, you can place something underneath the foot for comfort, but you see our central ray is going to be entering right there where an internal oblique should enter. And we're going to eliminate the distortion there. So this is kind of our last resort option, where we don't angle the board underneath our patient. And what's going to happen when we do this is it's going to distort the knee and elongate it sideways, so it's going to make it look really wide when you take this picture, but it'll still look like an internal oblique. So worst case scenario, this works.